Okay, chapter 15. We're going to talk about the secondary assessment. Some of the topics we're going to be talking the secondary assessment. We're going to talk about secondary assessment of the medical patient, secondary assessment of the trauma patient, and then we're going to talk about the detailed physical exam. The secondary assessment. Components of this assessment, we're going to have three different categories of patients. We're going to have a medical patient. We're going to have traumatic or trauma patients. These are people that are injured, or it could be unknown. We don't know exactly if it's a trauma patient or a medical patient yet until we roll out a few things. We'll do a physical exam. We'll gather a patient history, the history of the present illness, and a past medical history. And we're going to obtain vital signs, all in the secondary assessment. It's important to note the difference between a sign and a symptom. A sign is something that you see yourself. You visually see it. A symptom is something that the patient tells you. Reassessment is a continuous process. We'll be talking about reassessment in the next chapter, but just note that it's an ongoing process. All right, secondary assessment of the medical patient. Your assessment is going to vary depending on the patient's ability to communicate. A responsive patient can answer history questions, can tell you how they're feeling or giving you symptoms. An unresponsive medical patient can't answer any history questions. They won't be able to tell you what they're feeling, what's going on. Responsive medical patients, we're going to obtain a patient history. We're going to perform a physical exam. Usually, this is a focused exam on our responsive medical patients, which means they tell me that they're having difficulty breathing, so we're going to focus in on that respiratory system. We're going to obtain a baseline set of vitals, and remember, we always come in two. An ambulance has a pair or a team. So while one is doing the physical exam and history, your partner can be doing the vital signs. And we're also going to administer interventions and transport the patient. We're going to try to obtain a history from the patient first. If for some reason we can't communicate or the patient's unable to communicate to us, we'll go to family and bystanders next. We're going to base our questions on our chief complaint and observations. We'll use those open-ended questions, give the patient time to explain, and we'll use the sample mnemonic. And if you don't remember what the sample is, go back and review chapter 14. It goes into detail what the sample history is. Tailoring the physical exam for specific chief complaints. Important information can be gained by tailoring these history just to the patient's chief complaints. We're going to ask questions pertinent to that chief complaint. So, for example, if we're having trouble breathing, we're going to ask questions about the respiratory system and breathing. Like, are they in pain? If they have a history, stuff like that. Perform physical exam. It's usually brief. It's pretty quick. We're not spending an hour on this exam. Examine the areas of concern based on a chief complaint, which we call that a focused exam. So we're going to focus in on what they're complaining about. Obtaining baseline vitals, essential to assessing medical patient. And when we take further or reassess the vitals, that'll give us the ability to compare or trend our patient. And we're going to take a manual pressure to verify the accuracy of an automatic blood pressure device, right? We always teach that your first set of vitals, you take a manual blood pressure, then you use your auto blood pressure later and you compare that. Remember, decision for prompt transport of critical patients or those with specific complaints is part of your treatment plan. So if they're critical, we're not going to mess around. We're going to go ahead and get going. We can do the secondary assessment en route. Pediatric notes, always get down to the same level of the child. Make your question in simple language, like we talked about in earlier chapters. Instead of saying, "Do you have abdominal pain?" we ask them if their tummy hurts. And you will gather information from caregivers like parents or teachers or daycare providers. Now, when we have an unresponsive medical patient, uh, our exam, we begin with using the physical exam of baseline vitals. Then we worry about getting history from relatives or bystanders. And we're going to do a rapid assessment of the entire body. We call this the head to toe. And it's going to be a very quick, rapid assessment. We're going to start at the head and work our down our body, or the patient's body. Performing a rapid physical exam. So similar to a head to toe exam for trauma patients, we're assessing their head, neck, chest, the abdomen, pelvis, extremities, and the posterior. What we're looking for in the neck is JVD, or jugular vein distension. We talked about in earlier chapters, or the flat jugular veins normally. They may be distended now. That's a sign of cardiac issues. We're looking for medical identification bracelets around the neck if they're wearing a necklace. Chest, we're listening to breath sounds to make sure they are breathing. Are they adequate breath sounds? Or are they wheezing? They among others. The abdomen, we're looking for distension, firmness, or rigidity, which is all signs of internal bleeding. Pelvis, we're looking for incontinence of urine or feces. So did they pee themselves, or did they poop themselves? Which could be a sign of like a seizure, right? Or other, but especially a seizure. Extremities, we're looking for that PMS, that pulse, motor function, and sensation. We'll check their oxygen saturation, and we'll also look for medical ID bracelets here, like bracelets. They'll be around the wrist. Check for medical ID devices. And we'll check the pupils. Obtaining a baseline set of vitals. Again, chapter 13 talks all about vitals, but we're going to assess the pulse, the respiratory rate, the skin tone, the pupils, the blood pressure. We're also going to be checking their SpO2, or their oxygen saturation. And on our baseline, we're going to be checking the blood glucose level. Take a note of any abnormalities and determine the saturation, like I said. Consider requests for ALS, right? Follow your local protocols. They'll state you should consider ALS. Consider if a paramedic would benefit your patient. Not only a paramedic, but an advanced EMT. And you have to remember that not all areas have ALS as an option, but most areas at the bare minimum will have access to helicopters, and technically they are an ALS intercept. But if we don't have ALS or helicopters not available, we may consider the closest option for health facility. We may not go to that closest appropriate. We may just go to the closest at that point. Obtaining the patient's history. We're going to question bystanders for an unresponsive patient, like what's the patient's name? What happened? Did they happen to see anything? Was the patient complaining before this happened? Like, were they having chest pain, then they suddenly collapsed? Did the patient have any known illnesses or problems? And if they know if the patient takes any medications. We're going to look for mechanism of injuries or signs that suggest spinal injuries. And if needed, we're going to mobilize the patient. Medical history, we can get some off of medications, like you see in this picture. It says interview family bystanders for information about the present illness, OPQRST, and also the sample history. Both of those are described in detail in the last chapter. Very important that you know what these two mnemonics are. Mid-chapter review. The secondary assessment of the medical patient takes two forms depending on whether the patient is responsive, right? So a responsive medical patient gets a focused exam. We get the history from that patient. We do a baseline set of vitals. An unresponsive patient, we start with the head-to-toe exam and baseline vitals, and then we try to gather information from other sources like family, bystanders, medications, equipment, ID bracelets, stuff like that. You assess the response of the patient by obtaining patient history, then perform physical exam of the affected body parts before getting baseline vitals. Since unresponsive medical patients cannot communicate, it's appropriate to start the assessment with a rapid physical exam. Baseline vital signs come next, then interview the family, friends, and bystanders to get a history, just as I just stated. You might not change any field treatment as a result of information gathered here, but the results of assessment may be very important to the emergency staff, right? Secondary assessment of the traumatic patient or the trauma patient, patients that are injured. Remember, the injuries can be very slight, minor abrasions, all the way to severe, an amputation or a major head injury. We have to consider how serious it is by considering the location of the injury or injuries on a patient. The patient's mental status will help us determine how serious this is. So, an unresponsive patient is a critical patient. An unresponsive traumatic patient is critical, and we're going to transport pretty quickly. To determine how serious an injury is, we should consider the patient's airway status, their vital signs, the mechanism of injuries, because we may not see any outward signs, but due to the mechanism, we can suspect certain injury patterns, patient's age and pre-existing conditions. This is important, right? Younger people are more resilient, whereas old people are more fragile, and some pre-existing conditions like osteoporosis makes them prone to fractures. Maybe they have a calcium deficiency that'll be prone to fractures. So their bones are more brittle, more weak. Their vessels aren't as strong, so they can rupture easier. So, trauma patients with minor or low priorities. We're going to assessment is on focused on the area um, of painful, wherever they're complaining of pain, or that the mechanism of injury indicates. So, for a responsive minor injury patient, we're going to go to a focused exam. I twist my ankle and I say my ankle hurts. I'm going to examine the ankle. I'm not going to worry about doing a head to toe. I'm going to that ankle. Determine the chief complaint. We're going to conduct a history of the present illness to gain information on how the injury occurred. Determining the chief complaint. This is what the patient tells you is the matter. My ankle hurts. My arm hurts. My chest hurts. Obtain a patient history. We're going to notice the forces that are involved. Did they fall from 20 feet? Was it a massive car wreck on a rear end impact? The direction and strength of the force. Which way did this come from? So if we're falling, and the direction of the force is going to be a downward force. Did they have any protective equipment on? Is this a construction site and they were wearing a bump helmet or a hard hat and they got hit in the head? Or were they not wearing a hard hat and got hit in the head? Did they take any actions to prevent or minimize injuries? Like, were they falling? So they put their hands out or their arms out. Was something coming towards them, they put their hands up to protect their face and head. And we're going to look for the areas of pain and injuries resulting from this incident. Now, when we perform a physical exam on a trauma patient, the areas that we're going to assess depends on the injuries and the chief complaint. Remember that a mechanism of injury may point to potential injuries by knowing injury patterns from certain mechanisms. Of course, we're going to use the 3 techniques as well: the observation, palpation, and oscillation. Right? We're going to observe or look. We're going to palpate. We're going to feel. We're going to oscillate. We're going to listen, usually with stethoscopes. We're going to observe for abnormalities and symmetry. Does one arm look like the other? Does one hand look like the other? We're going to look for color. Because the injury site, below the injury site, may be off colored because it's not getting blood flow. Shape, is it deformed? Is it swollen? And movement, can they still move their fingers and their arm or whatever? We're going to palpate for abnormalities. We're going to feel for the shape of it. Is it swollen? How does it feel temperature-wise? Because an injury site is probably going to feel warmer, but below the injury site they could have a lack of blood flow due to a fracture, and it may be cooler than such. Texture, what's it feel like? And sensation, can they feel you? Auscultation, we're going to auscultate for decreased or absent lung sound. All right, these are important to know as well. These are what we're looking for with a physical exam on trauma patients. We're looking for decap BTLS, deformities, contusions, which are bruising, abrasions are like scrapes, like road rash, punctures and penetrations, burns. We're going to be looking for tenderness or feeling for tenderness, lacerations or cuts, and swelling or edema. Obtaining baseline signs. Early vital signs provide a snapshot of stability, right? If we have a high heart rate and a normal blood pressure, they could be in compensating shock. Maybe they have a high heart rate and lower blood pressure. Now we're decompensating due to like blood loss. And the baseline vitals they provide a baseline for future assessment that we can compare to or trend our patient. Spinal motion restriction, or SMR, and this is applying a C-collar. How are we going to do that? We apply a C-collar to any patient who requires spinal precautions due to mechanism or complaint of neck pain, back pain, head pain. Cervical spine immobilization devices should be rigid. We don't use soft collars in the field. You see that people come out of the hospital, they'll have that soft foamed collar. Ours are rigid. And we have to size it to make sure it's the right size. We have adjustable collars because not everybody's neck is the same size in both length or girth. And there's different sizes for different age groups. We don't want to use a pediatric collar on an adult patient or vice versa. Here's a picture of them measuring on the patient's neck using the finger technique. There they properly sized it. And you'll get hands-on experience doing this in class later on. SMR, applying a C-collar. We're going to complete the primary assessment and care for life-threatening problems before we worry about putting a C-collar on, right? So we're going to do a primary assessment, which is to find and rule out and fix life-threatening injuries or life threats. We can use the mechanism of injury and the patient's condition to determine if we need cervical immobilization, like I talked about. Or they have neck pain, they have head pain or back pain. Did they fall head first out of a tree stand? That's your mechanism. We're going to assess the patient's neck prior to placing the collar. So we're looking for decap BTLS on the back and the front of the neck. Because once we have the collar on, especially in the back, we're not going to be able to assess that patient's neck. Most C-collars have an opening in the front so we can see their like trachea or their Adam's apple. And we're going to reassure the patient. Here's a nice picture of them applying a C-collar in a seated position. So proper techniques, we're going to size the collar. We're going to remove the jewelry and move the hair. Keep the patients in that inline anatomical neutral position. Continue spinal stabilization. So we're going to take manual stabilization. Trauma patients with serious injury and multi-system trauma or high priority. We're going to take C-spine precautions. We're going to consider the need for an ALS or advanced life support personnel via paramedics or advanced EMTs. You're going to perform a rapid trauma assessment. This is a complete head-to-toe assessment. Here they're starting the head to toe. It starts with the head. We run our hands through the hair and looking for blood. We're checking for wounds, tenderness, and deformity, and crepitus. We also have to consider hidden injuries like seatbelt injuries, airbag injuries, steering wheel injuries. We may not see the outward sign initially, but we have to have that high index of suspicion because they had hit a steering wheel, when the car was doing 60. Consider spinal precautions, manually stabilize the patient's head, and follow your local protocol. And we'll go into great detail on this when we talk about spinal injuries and later on in this course. Paramedics can provide additional interventions. Follow your local protocol and familiarize yourself with what type of patients local clinics can help. And just in case you can't get to AOS there, you may go to the nearest facility. Performing a rapid trauma assessment requires only a few moments. This is hence the word rapid. We're not spending an hour on this. This is just a few moments. We perform this on scene. Care provided en route will be based on this assessment, right? So whatever we find in this rapid trauma is what we're going to fix later on, maybe, when we have more time. But going back to that, if we find a life threat, we're going to fix that immediately. Rapid assessment of the head. We're going to palpate the cranium, the face, the ears, the eyes, nose, and mouth. We're looking for blood or clear fluid in the ears, or battle signs. This is the bruising area at the ears. Or we're looking for raccoon eyes, the bruising area at the eyes. These are signs of basilar or skull fracture. We're going to rapidly assess the neck, looking for wounds, tenderness, deformities, JVD. We're going to check for stoma and the tracheostoma. We're going to apply a C-collar, size and apply it by your protocols after we assess the neck. Then we're going to move on to the chest. We're looking for that paradoxical motion or unequal movement, which means when I breathe in, a certain part of the chest will sink in. And if we breathe out, it'll push out. We're feeling for crepitus, and we're listening to breath sounds. Rib cage and chest must be exposed. You can't assess an area during a rapid trauma without exposing the area. So if you're dressed, you're not assessed. You're going to hear that a lot in the EMS world. Here's palpating the chest. He's also auscultating lung sounds. Then we're going to move to the abdomen. We're looking for distension, pulsating masses. We're going to gently press down on all four quadrants. We're going to rapidly assess the pelvis. We're feeling for bleeding and priapism. Priapism is an uncontrollable erection of the penis, usually due to nerve damage. Nerve damage in the spinal column. Here's a good example of palpating the quadrants of the ab. Then we're going to assess the extremities, usually the lower first, since we're already down there at the pelvic, and then we'll move to the upper. We're looking for wounds, tenderness, deformities. We're looking for that PMS, pulse sensation, and motor function. Assessing distal circulation, if the upper extremity, by feeling the radial pulse. So if we have an injury, we're going to feel for a distal pulse to make sure that the blood is still circulating. This is motor sensation, function. Are they able to move their hand up and down? And stress the hands by asking them to squeeze your finger, the strength. Checking distal circulation, lower extremities. For the posterior of the body, we're going to roll the patient on the side, then we're going to assess. Slide in an extrication device to ensure a movement of the patient. So this will be where we put them on a long spine board. Again, more detail later on when we're talking about the spinal injuries. Obtaining baseline vital signs and past medical history. They say use your pulse oximeter if applicable. I'm going to tell you on every patient you're going to. Here's them checking the back before they log running onto a long spine board. Some general principles. Tell the patient what you're doing, right? We're going to explain to them what we're going to do. Expose the injured area before examining it. maintain eye contact, apply spinal precautions, and stop or alter assessment process to provide care. That means if we find like a life-threatening injury or life threat, we're going to go ahead and stop and fix that before we move on with the assessment. Pediatric examinations. Do not apply pressure to the fontanelles because remember there are spots where there's no bone underneath. So if you put pressure, you're actually putting pressure directly on their brain. And remember, they got these big bobbly heads on skinny necks, so injuries can cause or collisions can cause head trauma or head injuries. When it comes to nose and ears, we're looking for blood and clear fluid. Mucus or blood clots obstructing can disrupt breathing, right? It can obstruct the airway. In the neck, partially larger heads, proportionately larger heads increase the chance of spinal injury. We just kind of talked about that. Big bobbleheads on these little toothpicks. And remember, can have spinal cord injury without spinal bone fracture. Airway, keep the infant's head in a neutral position. Chest, we're looking for even breath sounds. We're checking for symmetry, bruising, paradoxal movement, and retraction. And remember, retraction is when they're breathing in the above their clavicles or in the ribs will be sinking in. They're really working to breathe. In the abdomen, we're noting for rigid or tender areas or distension. These are all signs of internal injury. And remember, if they have injuries that impedes the movement of the diaphragm, this can compromise breathing because we have to have the diaphragm moving or contracting to create that negative pressure so we can breathe. We're going to check for stability in a pelvic girdle with pediatric patients. And we're going to examine their extremities for cap refill and distal pulses. We're going to check for painful, swollen, or deformed injury sites. A detailed physical exam, typically completed en route to the hospital. This is our secondary physical exam usually. Again, it's a slower exam than like rapid trauma or rapid head to toe for unresponsive medical patients. It helps us gather additional information because we're slowing down and we're really looking at these systems. It'll help us determine what treatment we're going to do if we find some additional information. This information will help the emergency staff later on in their testing process and their lab work. Performed most often on traumatic patient with significant injuries. So this is a secondary, more detailed physical exam. So it's a repeat of the head to toe. It's just we're moving slower. We're really looking in detail for that DCAP BTLS. Trauma patients with significant injury. You will assess almost the entire body during the rapid trauma assessment. And now you need to assess the entire body more thoroughly to possibly reveal signs or symptoms of injuries that you may have missed or have changed since that rapid trauma, right? So we're slowing down. It's a more detailed examination, and that's why it's called the detailed examination or secondary exam. Before beginning the detailed exam, remember to perform this only after you've performed all critical interventions. So you may not ever get to this stage in a severely injured patient. So don't perform this instead of doing a critical intervention. And remember, it's not a failure if you don't get to this stage. To perform a detailed exam, we got to expose the patient, right? If you're dressed, you're not assessed. So we got to expose them. Remember that some of the noise and motion may interfere with some procedures. We may not be able to hear lung sounds as well, go down the road at higher rates of speed. really noisy in the back of a truck. We have to work around immobilized patients. We can't take them off the backboard. We have to work around them. Can't take the neck collar or the seat collar off. So we have to work around that. And remember, it's just like your rapid trauma head to toe, but it's more detailed, more focused. So it's like a slowed down head to toe rapid trauma, and we're really focusing on looking for decap ETLS. Trauma patients who are not serious in injury generally doesn't need a detailed exam. So, for example, if I twisted my ankle, I don't need to do a detailed head to toe exam. I just need to do a focused exam, focused on an area that's hurt. But we have to keep a high index of suspicion. And when in doubt, just go ahead and do this detailed exam. And be aware patients are their fear and they may need emotional support. Let's do a quick chapter review. If a patient has significant or without significant mechanisms of injury, receives a history of present illness and physical exam focused on the area that they're complaining, right? So that goes back to if I twisted my ankle or a minor injury, I'm going to go focus in on that area that the patient's complaining about. I don't have to do this rapid trauma. I may not even have to do this big detailed physical exam. We're going to gather a set of baselines after we do our exam and a past medical history. If they do have a significant injury or mechanism of injury, we're going to provide spinal precautions. We need to consider if we need advanced LS or advanced life support. We may get a brief patient history, and we're going to perform that rapid trauma assessment. In this rapid trauma assessment, we're looking for the decap BTLS, wounds, tenderness, deformities, plus additional signs appropriate for the part being assessed. A systematic examine the head, neck, chest, abdomen, pelvis, extremity, and posterior. And if we do it that way every time, then it just becomes second nature and you just do it that way all the time. After assessing the neck, it may be appropriate to apply a C collar, right? Or we're going to assess the neck before we do the C collar. And after we do this rapid physical exam or the physical exam, we're going to go ahead and do the spinal motion restrictions, and we'll get a baseline set of vitals, and then we'll get a history, a medical history. And after all the interventions are done and we begin transport, this is where we go into that detailed physical exam while we're en route. Well, we have more time, and that's that slowed down, detailed exam. It could be head to toe, or it can be a focus as well. Remember, it's very similar to the rapid trauma, but we have more time to do a more thorough examination. And we're not going to do this before we go en route to the hospital unless we're delayed for some reason. The detailed physical exam is not the most appropriate for your trauma patients who are unresponsive or have a significant MOI or injuries. That would be a rapid trauma. And again, if they're a responsive trauma patient with no significant injuries or MOI, we seldom require a detailed physical exam. Remember, MOI, use the MOI to determine the need for rapid trauma. Assume spinal injuries, work as a team to complete assessments, right? Which means, well, I'm doing a detailed exam or somebody else could be doing vital signs, we could be getting history, all this other stuff. Work as a team. We assign roles and we do them. All right, that'll do it for chapter 15. So chapter 16 is coming up next.